thank you everyone for being here. I know you guys all have busy schedules and better things to do at home and so forth, so we thank you for taking the time and listening to us talk about some boring stuff. We want to thank the Circle of Excellence for being here, for just everything that you do. We wouldn't obviously be here with the technology that we have without you guys. Thank you to Amy, Stephanie, Breeze, everyone who's kind of put this event together, so thank you so much. So, like Dr. Shao, the hip and the knee is a pretty complex joint. There's a million different diagnoses out there. Because we were only given 15 or 20 minutes, I kind of decided to kind of focus on the hip and knee arthritis, which is a little bit more catered to our audience today. This is my princesses. Kayla's 4 and Maya's 2, and their mom in Maui, Hawaii this past summer. Objectives tonight, we'll kind of talk about the diagnosis and treatment of arthritis, and then talk about some of the new stuff that PIH Health is offering for our patients. So arthritis, it's a progressive disorder. Most of the time, it's idiopathic, meaning we don't really know why it happened. People always want to know, did I do too much, too quick? Is it my parents to blame for, and so forth? The reality is that it's multifactorial. A lot of different things contribute to it. But in the end, what it causes is that you've lost the protective mechanism in your joint, causing you to have pain and deformity in the hip of the knee or the shoulder. Who gets arthritis? So basically, anyone can get arthritis. It's most common in the weight-bearing joints, the spine, the hip, the knee, the shoulder. Age is probably the biggest risk factor for arthritis. It says here that over the age of 70, 50% of patients have some form of arthritis. Under the age of 40, it's much less common, although in my practice, I'm starting to see it much more common. I've kind of shared with some people today that last month I did 4 hip replacements, all in their 30s. So it's becoming more and more common these days. Obesity, so unfortunately, as we gain some weight and so forth, it puts extra stress on our joints, and it causes an acceleration of arthritis. And as I said earlier, gender and age. Women, for whatever reason, are just more prone to arthritis. Genetics, hormones, joint laxity, and so forth. They're just more active than men, too, so that causes that. Signs and symptoms of hip and knee arthritis: morning stiffness, difficult time getting up and walking around, then you feel kind of good. By the end of the day, you're having a lot of swelling and pain. You have a difficult time sleeping. You're having issues going up and down stairs, getting out of a chair, and so forth. So what are the goals of treatment of arthritis? First and foremost, it's pain. That's the number one thing, is people don't want to live with pain. So how do you control pain? And then improving functional status. I was able to walk and hang out with my grandchildren. I was able to hike and do all these things, and I can't do that anymore. What can I do to get my quality of life back? So going over a little bit of treatments for arthritis, we always start off with the easy stuff, right? We start off with education, doing things to help prevent pain, warming up, stretching, icing after activities. We talk about weight loss, like we said earlier. You know, unfortunately, as we get a little older and we gain some weight and less active, it puts a little extra stress on our joints. Bracing, walkers, canes to help us from preventing us from falling because of our joint pain. Physical therapy, and then we go on to our medications. So Tylenol is kind of like our bread and butter. That's the easy stuff, low side effects. We always start with that. Anti-inflammatories are very, very helpful, but come with side effects. People have very sensitive stomachs, they have heart conditions, they're on blood thinners, they have kidney issues, so it's limited in who can take it, but it's very, very helpful when you can. Cortisone injections, which we'll talk about, and then our opioids, our narcotics. Yes, it helps prevent pain, but it's something that we try to avoid. We want to try to solve the problem as opposed to kind of putting a Band-Aid on it. Cortisone injections, so also a very kind of bread and butter for us in terms of treatment of arthritis. You know, when it gets to a point where the medications, the activity modifications, the therapy is not helping, we consider cortisone injections. One of the most common questions we get is, you know, hey, I heard from a friend that it damages your joints. So yes, there's a lot of information out there on the internet, but studies have shown that steroid injections are very helpful and can be done safely. If we do it in the right patient, we limit it to 3 to 4 times a year, it's very safe and it does not cause more damage or harm to our joints. So then the controversial treatments. You know, a lot of people spend a lot of money on, you know, the joint-free, the glucosamine and so forth. The reality is that there's no studies that show that it actually does anything. I tell my patients, listen, if it works and you're willing to pay the money, go for it. I have no problems doing it. But if you ask me, do I recommend it? I say there's no studies that suggest that it actually does anything. Acupuncture, chiropractor are also a very common thing. I personally am not a huge believer of it, but I don't claim to know everything. My mom uses acupuncture and chiropractic and she swears by it, and I always encourage her, like, how was your last session? And she loves it, she swears by it. So I encourage it, but I don't ever promote it. And there's no studies that actually show that it does anything. Once again, we don't know everything. Just because the studies haven't shown that something is effective doesn't mean that it won't work for you. So kind of we talked about activity modifications, weight loss, therapy, pain medications, injections. And when all else fails, but most importantly, when your quality of life is affected by it and there's no other option, I think surgery is kind of the end-all be-all, but not for everyone. So I'll kind of go over some hip and knee arthritis diagnoses and treatments. We'll start off with the hip. Hip arthritis is a degenerative disorder of the joint. We wear down the cartilage, and then you've lost the protective mechanism of the joint and it becomes bone on bone, causing you the signs and symptoms that we've talked about. You start walking with a limp. You have your hips pop in when you're getting in and out of a chair. You have a difficult time sleeping at night. Your hips grinding. You can't put on your shoes anymore. So if we look at Xray findings here, here's a normal hip on the left hip. You can see this space, probably hard to see. That space represents cartilage, and that's normal. If you look on the right hip, there is no joint left. This person has lost all of the cartilage. They're bone on bone. As a result of it, they've created bone spurs, which is kind of the protective mechanism that your body produces in response to the arthritis. You get bone cysts, which is very common in arthritis. It's the way of the bone remodeling as a result of losing the protective mechanism. And then hardening of the bone. Normally you have cartilage, you have joint space, it glides very nicely. When you're bone on bone, the bone becomes really hard and brittle. So you can see how white that joint is, and that's because of the sclerotic margins of the bone. So we've done hip replacements. Well, I didn't, I was a little too young for this, but in the 1950s we started doing them. It's becoming more and more popular. We do about 300,000 across the country. The estimate by 2050, I believe it's going to be about 900,000 hip replacements each year. As the baby boomers are more active and doing more things, more hip and knee replacements are becoming more popular. The main goal for hip replacements is always pain relief. Unfortunately, hip replacements don't take turn back time. We can't make you 30 years old so you go back and do things. But with that said, as I said, our technology is getting better. The way we're doing our surgeries are getting better. So people are going back to normal lifestyles. I mean, people are surfing, playing volleyball, hiking, and doing all those things. So we've come a long way in terms of how we do our surgeries. So here's just a diagram of what a hip replacement looks like. Going back here, if we look at this bad hip here, we make a resection, remove the bad bone, we replace it with the femoral stem, which goes inside the hip replacement. And then we put a ball and socket, and that's what a hip replacement looks like. So different ways of doing hip replacements. The surgical approach, there's a million ways to skin a cat. And it really comes down to surgeon preference. People have trained different ways. I've kind of had the privilege of being a little younger and training in a different generation where the anterior hip has become popular, but there's a lot of people still doing posterior, lateral, and different approaches of the hip, and they're all successful. Patients do great. Hip replacements is one of those surgeries that's life-altering. It really gives you your quality of life back, and I think that, for the right patient, with the right surgeon, regardless of how you do your hip replacement, it's a great outcome. So the posterior approach, it's the most traditional or the classical approach. The majority of surgeons, I think to this day, are still doing the posterior approach. You make it, the patient's laying on their side, you make an incision through the butt, it's been tested. There's great outcomes. Patients do very, very well. One of the biggest advantages is that it provides for great exposure. So in the challenging cases, the larger, heavy-set patient and so forth, this approach allows you to do all comers. Some of the disadvantages, unfortunately, of the posterior hip is that it's associated with higher dislocation rates. So one of the big concerns and fears of doing a hip replacement is, can I do this without my hip popping out? Can I do that and do so forth? So with the posterior approach, there are unfortunately a little bit more restrictions into what you can and cannot do. So the direct anterior approach is what I do. It's the so-called minimally invasive approach. And the reason for that is that it's how we approach the hip. About 20 or 30 years ago, we started doing hip replacements from the front, and it's gaining popularity. We make an incision from the front of the hip. Patients are laying on their front. We don't have to cut through any muscles, tendons, or ligaments. We kind of go in between the muscle planes to access the hip. And the advantage of that is that it's a quicker recovery. There's less pain because we're not cutting through any muscles. Faster rehab. And most importantly, I don't have restrictions for my patients. My patients can go out and do whatever it is that they want to do. We actually just had a patient that I saw for a 6-month visit. He's in his early 40s, he's a jiu-jitsu, I guess, master. He owns his own studio. And he sent me a video of him doing a forward flip off a 10-foot lever after a hip replacement. So we've come a long way in how we do hip replacements. This kind of medieval torture device is our Anterior, is our HANA table. This is my passion. This is what enables me to do what I do. There's some surgeons who do the anterior approach without this device or table, but this table allows me to really truly access the joint without having to do further dissection and releasing the soft tissues and so forth. So I get to cheat a little bit. I get to use this machine to help expose the hip so that I can do a better job, so that patients have less pain and a quicker recovery. This is an illustration of what an anterior hip approach looks like. Once again, we kind of go in between the muscles, so we don't have to cut through any muscles. We get great access and visualization of the hip joint. And this is all done through a small 3-inch incision from the front of the hip. I get to use X-rays during surgery. There's no surprises for me. I know exactly where I'm placing my implants. I get to pre-plan my surgery. I get to execute it, and I get to use X-ray to confirm what I'm doing. So with this, I don't have to wait until the patient's in recovery and get an X-ray and then, oh, that's a little off from what I expected. I get to know. I don't leave the operating room until I know exactly where the hip is placed. So some of the, basically early outcomes and so forth, we've shown that, now it's becoming more popular. Does it actually do anything, right? And so the studies are proving and showing that patients have faster recoveries, less pain, shorter hospital stay. Patients are just generally doing better. With that said, this is not the only way to do hip replacements. We have phenomenal surgeons within our group, within the organization, who do the posterior approach, and they get phenomenal results. This is just how I train, this is how I like to do it. So I'm a little biased. So moving on to the knee. Once again, knee arthritis, very similar to hip arthritis or shoulder arthritis. It's the loss of cartilage. It's bone on bone, remodeling of the joint, causing pain, instability, and deformity. You'll note some people have, the bowed-legged or the knock-kneed and so forth. That's a result of the fact that you've lost the cartilage and your bone's remodeling as a result of it. Same thing with the X-rays here. If you look on the outside of the joint, this big old space, that's normal. That represents cartilage. The inside point of the joint, it's gone. The cartilage is gone. You're bone on bone. You're creating arthritis, bone spurs, hard bone. So treatments for knee arthritis. Unfortunately, we talk about all the conservative stuff that we did earlier, but in the end, the only way to there's no way of reversing arthritis. The only thing that we can do once we kind of failed all conservative measures is the knee replacement. So the first knee replacements were done in the late 60s. It's a very, very common procedure. We're doing about 600,000 a year. I think the numbers for 2050 is over 1 million knee replacements a year. So they're very, very common. Contrary to belief, people think we kind of make a resection, cut bone here, and put a mechanical block, and that's what a knee replacement. It's actually more of a resurfacing procedure. So we kind of remove and shave off some of the bad bone, and then we cap it with our prosthesis, and that's what a knee replacement looks like. So the cemented knee replacement. This is the most common technique that we use. It's still, most surgeons use this. We make our cuts, we prepare the bone, and then we put a cement or a grout, or basically a bone glue, and we paste it onto the implant, and within 10 minutes, it's completely solidified to the bone. We're not worried about anything. So it's a great, great way of doing knee replacements. Some of the advantages is that for the older population, who are the majority of our patients, their bones become a little soft, osteoporosis or osteopenia. Those bones require the glue to kind of cement in the implant. The potential disadvantages is that because we're relying on a glue or cement between the interfaces, there's the possibility that over time, cement weakens and the implants can become loose. But we know that the way we do it now, these knee replacements are lasting well over 30 years, which is, if you would have asked that question about 10, 15 years ago, we would say, wait for as long as you can, because these things are only lasting about 10 years or so. I think that things are very different these days. Here's just an example of a recent knee replacement that we did using cement. Cementless knee replacement. So a lot of patients are asking me about that. It requires or relies on a special implant. In this particular example, we use a trabecular metal. It's a very special metal that allows the bone to grow into the metal. So the advantage of that is that instead of relying on a glue, the bone grows in, integrates into the metal, so it becomes one. So the chances of it becoming loose over time is less common. The indications for it are more narrow. It was initially designed for the younger, active patients who put more wear and tear on their joints, so that's how you do it. Some of the drawbacks is that it's a harder surgery to do. You have to be more precise, there's higher complication rates and so forth. But because of the way we're doing things, because of technology and advancements, we're just doing it more common now. I no longer use age as an indicator for who is a good candidate for cementless knee replacements. If your bone is good and you're 70, 80 years old, you can ask Dan, who's the rep that I operate with every day. We've put in cementless knee replacements in 80-year-olds because their bone quality is so good. So age is no longer the requirement, it's just how good your bone is. So partial knee replacements or unicompartmental knee replacements. Instead of resurfacing the entire knee joint, the medial and the lateral and underneath the kneecap, your patella, we can do an isolated medial compartment knee replacements. Some of the advantages is that we preserve all the soft tissues. We keep your ligaments intact, so it's a quicker recovery. It feels more natural. People kind of move on with life and forget that they have a partial knee replacement. Unfortunately, with the knee replacement, even though patients are very happy and don't have pain, they always know I have a knee replacement. It's a mechanical feel. The partial knee replacement is a little different. Unfortunately, it's just the indications for are very narrow. There are very, very, very strict criteria as to who's a good candidate. People have tried to kind of push the indications, and we're seeing that some patients are requiring redo surgeries, within 10, 15 years and so forth. So it needs to be done under the right hands for the right patient. So what's new at PIH? Since I joined the organization, we started our rapid recovery program. Amy Lee, who's our coordinator and nurse practitioner, helped bring this program to life. When I first started, and I said, hey, listen, I plan on having our patients go home the same day. The nurses looked at me like I was crazy. They're like, these patients are old, they don't have support, they can barely walk, there's no way you're doing this. And sure enough, a year and a half later, we're now doing outpatient surgeries. Our patients are coming in, having surgery in the morning, getting early rehab, and going home by noon. So things have changed. It's amazing what we can do these days. Once again, the indications, we have to make sure we have the right patients. It's not about age, it's not about the medical problems that you have, it's about the support staff that you have at home and your willingness to do all these things, right? I can do my job, we can do our job, but if we're not communicating this with you and you're not invested in this, you're not gonna do well. But with that said, we've been doing this for over a year now. We haven't had any complications. Our patients are doing very well. Studies are showing that this can be safely done. Some of the things that we're doing with this is that instead of general anesthesia, where we kind of paralyze you, put a breathing tube down you, and the way we used to do surgeries, we're now doing spinal anesthetic. So we're giving you an injection in the back. You're numb from the waist below. The difference is that you're snoring, you're breathing on your own instead of us putting a tube down your throat to breathe for you. So some of the advantages is that you wake up faster, you wake up with less nausea and vomiting, you wake up less groggy, less confusion, less blood loss, lower risk for blood clots. So the advantages go on and on and on. But this allows you to, within hours of waking up from surgery, getting up, working with therapy, walking up and down the stairs, and going home. And that's a remarkable thing. We've come a long way in terms of, 10 years ago, patients who were having knee replacements and hip replacements were in the hospital for 7 days. And now we're sending them home the same day. With that said, for the patients who do stay the night, it's one night. You spend the night, you do some therapy in the morning, and you're going home. So it's truly a remarkable experience. So this is why a lot of us are here today, is to hear about the new technology. PIH Health we were excited to partner with Zimmer Biomet. to bring the latest robotic technology to PIH Health to help aid our surgeons in providing excellence in joint replacements. ROSA, this beauty over here, is our new robot that we acquired at the hospital. It's currently on the second floor, and we're anticipating launching robotic surgery in the next couple of weeks. Basically, ROSA Robotics allows us to truly customize and personalize how we do surgeries. Yes, arthritis is simple. Loss of cartilage, deformity to the joint, pain, replacement. But every knee, every hip, every patient is unique and different. So we're foolish to believe that we can do surgery the same way for every single patient, for every single knee, every single hip. There's personality to every knee, every patient, and we should personalize how we do our surgeries. And that's how robotics allows us to do that. We're able to pre-plan our surgeries before we even walk into the operating room. I get to sit in my office, I get to look at x-rays, I get to plan out how I want to do my surgeries. I do it, I execute, I confirm, and patients are happy. So once again, I'm using technology to cheat in my advantage to help me provide better care for patients. Like I said before, we get to plan, right? So instead of going in there and saying, oh, this is a bad knee, we'll do our normal stuff or cookie cutter stuff and see how things go, release here, release there, we're now able to plan all this down to the compartment pressures. So instead of having to release and do soft tissues and doing a more extensive approach to surgery, we get to plan and make sure that we have a well-balanced knee. So, some of the earlier robotic technology before ROSA came along, there wasn't really any evidence to show that did robots actually improve surgical outcomes. That's the holy grail, right? Why are we doing this? And there are some newer studies to show that with the latest technology and some of the stuff that comes along with it, we're able to more precisely, more accurately do our surgeries so that patients have faster recovery, less pain, and most importantly, better functional outcomes. This is our ROSA hip, so basically showing how we use it and incorporate. Once again, with the anterior approach, I get to use x-rays, I get to cheat, but there are flaws. Not all x-ray machines are the same. The way you do it, the technique that you do it can cause discrepancies in what you plan and what the outcome is. ROSA will allow me to take away those little discrepancies, to more accurately do my surgeries. One of the biggest complaints and concerns that patients ask me is, hey, so I heard that the anterior approach, you can better, so I won't have one leg longer than the other and all this other stuff. ROSA will allow me to do that surgery and more confidently tell you that yes, we've equaled out your legs, there's not one longer than the other, and that I put my implants where I intended them, where they're most stable for you, and so forth. So, ROSA, she's more than just a robot, right? There's a lot of cool and unique things. A lot of people have asked me, hey, well, why are you only doing robots now? With that said before, there was a lot of different robots out there and so forth that I didn't really think that I had training, I'd done enough replacements, I didn't need a robot to tell me how to cut something, how to do all these things. ROSA has really revolutionized how we think about surgeries and joint replacements. MyMobility is an application. In 2018, Zimmer Biomet partnered with Apple, the great Apple, to create this program called MyMobility. And basically what it allows us to do is from your Apple Watch or your phone, we're able to kind of track and monitor how patients are doing before, during, and after surgery. So it allows patients to be completely involved in their care. Patients are no longer saying, well, how am I doing? Or, hey, I'm concerned about this. Now, from this application at home, you can say, hey, listen, here's my wound, take a picture of it, it gets uploaded into the system, I get to look at it from my office and say, not a big deal, or yes, you should come in. Or it says, hey, listen, this patient is not walking enough today. So I sent a little reminder saying, hey, Rosa's telling me, you're not really doing your job today, don't make me look bad. With all jokes aside and so forth, it really has opened the door for us to be more involved, more engaged with our patients. We're no longer just doing surgery and saying, see you, when you come back, come let me know when there's a problem. Now we're kind of involved. We're kind of, I don't want to say holding your hands, but we're just more engaged, and the patients have more control over their outcomes. So when I started this venture and I kind of proposed, hey, can we consider acquiring a robot to help with their surgeries? One of the biggest questions I had was, well, why, right? PIH, we're doing great work, our patients are happy, we have great outcomes, complication rates are low. My question to them is, why get complacent with being good? Why not continue to strive to be better for our patients, providing more technology and doing the right thing to just continue to improve? And I'm just so excited, as you can see, about some of the things that we're doing with the support of our foundation and our support staff and so forth. I just feel like PIH is really heading in the right direction. So ROSA is one of the big steps that we're at least taking in joint replacement surgeries. Some of the other things that we're looking into and so forth is this thing that Dan actually has, or the team, Zimmer Biomet team has over there. It's our world's first smart implant. We have iPhones and Apple Watches and all these other things that are kind of helping make life a little simpler and easier, right? People, everything's within your hands. And now this implant, basically there's a tracking device within the implant that allows us to really fully engage with patients. We can really track live, real time, how patients are doing, how fast they're walking, and most importantly, to recognize when problems may be coming before patients or even doctors even realize it. So for instance, infection is a big concern of ours. We always worry about how to mitigate infection. And so with this implant, it can detect small changes in temperature within the joint to tell us, hey, something's not right here. This temperature is a little high. Maybe there's a concern for infection. Maybe we need to kind of engage the patient, have them come in and test their fluid and so forth. So this is kind of one of the new stuff that we're kind of looking into. We don't have it yet, but this just kind of shows and represents that we're constantly trying to get better. We're constantly trying to figure out how to improve and how to provide better care. Thank you, guys.